The Covid-19 pandemic brought significant and rapid changes to people's everyday lives, though not all populations experience these changes equally. Many researchers found certain characteristics such as ethnicity, age, or sex to have an impact on the severity of the virus. In this presentation, I will be discussing the disproportionate effect COVID-19 has had on Black, Asian, and minority ethnic groups in the UK. I will use a social science lens to explore the reasons as to why this occurs, assessing biological factors and the social determinants of health. I will further explore how occupation may be an additional risk factor for ethnic minorities. This presentation will conclude with some policy suggestions that Parliament must consider to ensure real and meaningful change and prevent this social issue from worsening in the future. During the significant spike of admissions to hospital and the use of critical care beds in April 2020, the Intensive Care National Audit and Research Centre made the observation that people from BAME groups seem to be dying disproportionately from COVID-19. They reported that 35% of patients critically ill with confirmed COVID are from the BAME population in Britain. This is disproportionately high given that BAME groups currently comprise only 14% of the UK population. This is shown on the graph to the left, in which it is demonstrated that Black groups are almost 5 times more likely to die from COVID-19 than their white counterparts. Though Chinese and mixed groups are much lower on the scale, they still face twice the likelihood of dying from the virus than those of white ethnicity. This likelihood was clearly represented in the death toll during the first wave, with the Black African group experiencing the highest rate of death. For males, this was 3.7 times greater than the white British group and 2.6 times greater for females. In addition, 63% of care workers who died were from ethnic minority backgrounds. This is overwhelmingly high considering BAME groups only make up 21% of all staff. The Office for National Statistics further identified that from September 2020, during the second wave of the pandemic, the COVID-19 mortality rate increased for people of Bangladeshi and Pakistani groups in comparison to the white British population. This led the Bangladeshi group to have the highest death rates, being 5 and 4.1 times greater than for white British males and females respectively. Those of Caribbean and Black African background remained at an elevated risk during the second wave, whilst white British people experienced a reduced risk in comparison to the first wave, further demonstrating the disproportionate effect on ethnic minorities. Though this data is in relation to the UK, a similar trend appeared to be happening across the United States. Reports showed that disproportionate numbers of Black Americans died from COVID-19 in New Orleans, Detroit, Chicago, and Milwaukee. This led to Black groups in the States facing major concerns about their health. Pew Research Center found that 46% of Black groups suggested that they were seriously worried, compared with only 21% of white groups. These harsh statistics demonstrate the alarming inequalities ethnic minorities have faced during the pandemic. As stated by Public Health England, the pandemic has created an opportunity for fast and sustainable change that must start now, though it's first crucial to understand the reasons behind why this has occurred in order to ensure that these changes are sustainable and effective. This is also vital in ensuring that inequalities are not exacerbated by viruses in the future. It has been difficult to determine exactly why BAME people experience the virus much more severely and with more adverse outcomes than white British groups. Some research has been carried out investigating the possible link between ethnic minorities suffering with increased vitamin D deficiency, increased inflammatory burden, or a higher prevalence of cardiovascular risk factors. The American Surgeon General Jerome Michael Adams also placed emphasis on the biological factors that may have contributed to minorities facing a greater risk of catching and dying of COVID. He identified that people of colour carry a greater burden of chronic health conditions, such as the development of high blood pressure in African Americans at much younger ages. He also highlighted that young Black males are 3 times more likely to die of asthma than their white counterparts. However, many initial explanations tended to focus on behaviour. This includes Adams, who initially put forth the explanation that these inequalities are down to the behaviour of African Americans. He urged them to change by encouraging people to stop smoking, drinking, and doing drugs if they wanted to protect themselves and those who are most vulnerable. However, this reasoning for the disproportionate effect COVID has had on BAME groups does not fit in line with the underlying causes of inequalities which we understand. Black, Asian, and minority ethnic groups experiencing inequalities is a deep-rooted issue that has been occurring for long before the pandemic and was brought into stark contrast by COVID-19. Though biological factors like health conditions are contributing factors, it is fundamental to consider the burden of social ills. Thus, the issue that needs to be addressed concerns the pre-existing inequalities ethnic minority groups have faced prior to the pandemic that have exacerbated their experiences and outcomes during COVID-19 in comparison with white British groups. Patel highlights the importance of this in understanding the grave outcomes for these communities. The Whitehall study demonstrated that we need to think beyond behavioural characteristics of inequalities in health and focus more on the social determinants of health. The World Health Organization's Commission on Social Determinants of Health has defined them as the conditions in which people are born, grow, live, work, and age, and the fundamental drivers of these conditions. This extends to an individual's social and community networks alongside the socio-economic, cultural, and environmental conditions that people live in. Ethnic minorities often face inequalities in these areas. with less resources to access healthcare services, safe housing, adequate food, good income, and poor working conditions. This in turn makes these groups increasingly vulnerable to health risks. The COVID-19 pandemic demonstrated that groups who face inequalities in these areas experience a higher risk of developing non-communicable diseases like heart conditions, asthma, or diabetes. When combined with the virus, their symptoms are much more severe, making the risk of mortality higher. This was recognised by Professor Kevin Fenton, who stated that those living in more deprived parts of the country are twice as likely to contract the virus and twice as likely to die. Similarly to Edgar Sinderstryker's observation of inequalities by socio-economic class in the 1918 Spanish influenza epidemic, where significantly higher incidences occurred amongst the working class. Therefore, the experience of Black, Asian, and minority ethnic groups during the pandemic fits into a much broader pattern of inequalities in health and society that must be addressed. For the purposes of this presentation, I will be focusing on how employment can determine one's exposure to the virus. It has been demonstrated that inequalities in the work sector interlink with the disproportionate effect COVID has had on ethnic minorities. Flexible work is unpredictable and stressful in ordinary times, but the pandemic has worsened this by adding a deadly aspect. The majority of workers in these roles seem to be occupied by ethnic minorities. They commonly carry out work in occupations such as cleaning, catering, sales, and customer service, all of which receive low wages. During the pandemic, individuals with these jobs were not able to carry out their work from home, and social distancing was often difficult. This was highlighted in the United States, with only 1 in 5 African Americans and 1 in 6 Hispanics occupying a job that allows them to work from home. This is worsened by the current £95.85 per week that is offered for statutory sick pay in the UK, or in some cases, individuals offered nothing at all. Therefore, many low-income individuals cannot afford to miss work to isolate, especially when ethnic minorities are also overrepresented amongst those with no recourse to public funds. The economic downturn caused by COVID-19 also meant that many workers in flexible jobs were much more likely to be let go, whereas predominantly white middle-class employees in professional or white-collar occupations have maintained relative security with the ability to work from home, receive furlough, and job stability. Therefore, ethnic minority groups occupying the majority of flexible professions that produce lower wages means that lower income areas are disproportionately filled with ethnic communities. Thus, those in lower paid professions and those living in poorer areas are most likely to be exposed to the virus due to the existing inequalities in society. Moreover, ethnic minorities in deprived areas are also increasingly likely to be living in densely packed areas with poor quality housing and overcrowding. This is made increasingly harder due to the disproportionate benefit caps like the two-child policy have on minority claimants. The pandemic highlighted that these groups are in need of access to social security systems and benefits the most. Patel highlights the link between these conditions and the high risk of mortality from the virus, further justifying the need for policy response in this area. Despite the low income flexible work generates and the little respect it receives, during the pandemic, many of these workers were labelled as key workers and were asked to continuously work throughout lockdown. With over 50% of frontline staff being from ethnic minority backgrounds, this put them in an even higher risk of contracting the virus and suffering severe outcomes. Even more so with the scarcity and unreliability of PPE sources for key workers. All key workers in the NHS and social care sectors rely on PPE to protect themselves from contracting the virus when treating patients. The shortage of sufficient and appropriate PPE across the UK means that all staff have been working in potentially unsafe environments. Though this is a big risk for all, individuals from ethnic minority backgrounds carry a greater risk, but are twice as likely to not speak out about workplace safety concerns as they do not feel secure enough to do so. This further compromises the safety of this already potentially at-risk group. Despite this, the government has continued to ignore the heightened risks that certain groups face due to structural inequalities. This supports the view that ethnic minorities were the most severely hit during the pandemic, which could be potentially as a result of the types of jobs they have or of losses as a result of the COVID crisis. Therefore, it is clear that people of colour are socially predisposed to COVID-19 exposure and have a higher incidence of the very diseases that put you at risk for the severe complications. This has led scholars to argue that for the most disadvantaged communities, COVID-19 is experienced as a syndemic, a co-occurring syngenetic pandemic that interacts with and exacerbates their existing non-communicable diseases and social conditions. The syndemic nature of the threat we face means that a more nuanced approach is needed if we are better to protect the health of our communities. As Kevin Fenton says, when we know better, we must do better. This presentation will now explore various policy suggestions to aid those most badly affected by the pandemic and ensure that inequalities do not continue to happen. If policy responses to COVID-19 are to benefit ethnic minority groups as much as others, future studies must include fundamental social concerns like racial discrimination and economic disadvantage and how they theorise and measure the impact of COVID-19 on ethnic minority communities. Health-related challenges need to be dealt with at the level in which they arise, A one-size-fits-all approach will be insufficient and unsustainable for communities facing disproportionate effects of COVID-19. Policy needs to be adapted to the level at which health challenges occur, whether that is local, national, or global. There is already enough evidence to justify an action plan to protect Black, Asian, and minority ethnic groups from the pandemic, alongside many reviews and reports that have put forth recommendations to tackle health inequalities. Yet the government has never acted on these. Instead, the responses by the government had adverse effects on ethnic minority groups. Brown recognised the paradigmatic failures of the global pandemic control, highlighting that the insufficient planning, inconsistent rules, and the failure to contextualise the risk of COVID-19 in relation to other health challenges all contributed to this disproportionate impact on ethnic communities. It is vital for the government to put policies in place to ensure health inequalities are not further entrenched by the pandemic. The first policy recommendation I will explore is by Public Health England in their report released in June 2020 on understanding the impact of COVID-19 on BAME communities. Public Health England proposed for the government to fund, develop and implement culturally competent COVID-19 education and prevention campaigns, working in partnership with local BAME and faith communities. This would reinforce individual and household risk reduction strategies, rebuild trust with and uptake of routine clinical services, reinforce messages of early identification, testing and diagnosis. In addition, it would better prepare communities to take full advantage of interventions, including contact tracing, antibody testing and vaccine availability, in turn protecting them from facing such severe outcomes of the virus. In the report, Public Health England further recommended that increased efforts be made in targeting culturally competent health promotion, disease and prevention programmes for non-communicable diseases. This would include the promotion of healthy weight, physical activity, smoking cessation, mental well-being and effective management of chronic conditions such as diabetes and asthma. These recommendations would help to mitigate the impacts of the pandemic on BAME people through early prevention of comorbidities, culturally competent guidance, and tackling existing inequalities. However, more focus may be needed on the mandatory collection of ethnicity data concerning COVID-19. The House of Commons and Women's and Equalities Committee on the Unequal Impact of Coronavirus on BAME People has put forward recommendations to ensure that occupation is considered as a risk factor when assessing the impact of COVID-19 on BAME people. It was established that there is a link between the occupation of a person and their exposure, vulnerability, and risk of contracting the virus. The Commission proposed that the government extends the eligibility criteria for statutory sick pay to ensure all workers on zero-hour contracts can claim. They also recognise the need to review the way zero-hour contract policies operate and the impact they have on BAME people. These reforms would successfully help to mitigate the coronavirus-related impacts on flexible workers, but also goes further in tackling the longer-term impacts of flexible work, including poor quality of jobs. Though this may not go far enough to create large-scale change, a more drastic approach could be required to effectively mitigate this disproportionate effect on all ethnic minorities. The Black, Asian and Minority Advisory Group produced recommendations in their report aimed to improve the experiences of ethnic minority workers and recipients of care within the social sector. Through consultations and using co-production principles, they established how BAME people felt that their ethnicity contributed to them receiving a poorer standard of care throughout the pandemic in comparison to their white counterparts. The advisory group recommends for an increased robustness in coordination of the health and social care system to better support BAME staff in the social care sector. This should include risk assessment processes and procedures, protective measures, campaigns and guidance for NHS and local authority, social care and public health. The advisory group further highlights the benefits of open line communication with Black, Asian and minority ethnic communities for understanding the experiences and implementing the correct changes needed. They also stated the importance of individuals from ethnic minority communities who have direct experience with the care sector, either as workers or recipients, to be at the forefront of the development of social care policy. This ensures that policies will reflect the needs of those who experience the high impact of the pandemic the most and allows for a diverse range of voices in policy making to influence decision making that supports all groups in society. Though it is difficult to know how far the experience of these groups will go in targeting the adverse outcomes of ethnic minorities by the pandemic. Despite the successful vaccine rollout and the effective medical responses, society cannot be truly COVID secure until we use a social science lens to tackle existing inequalities that have been exacerbated by the virus. Ultimately, as Brown says, the government must focus on longer-term preventative policies and methods to tackling the pandemic, based on a holistic view of people's health rather than short-term curative policies. Each policy recommendation would be successful in remedying this issue, but the recommendations set out by Public Health England would be most beneficial as it encompasses a range of issues that collectively work together to prevent the disproportionate impact on ethnic minorities. Through educational risk and reduction strategies, individuals can take full advantage of interventions to better protect themselves as well as their households. It's crucial for strategies and policies to reduce both pre-existing inequalities and the inequality caused by the social determinants of health, to create longer and sustainable change. The most effective way to do so would be to encompass recommendations proposed by the BAME Advisory Board and have individuals from ethnic minority communities who have direct experience with the care sector be involved in developing social care policy. As long as there is transparency and consistency among those delivering the rules, these policies are likely to be successful in eroding the disproportionate impact on BAME groups.